Hello and welcome. The purpose of this PowerPoint is to present an overview of the concept of inflammation for NUR 200 and what I like to call the itises, which is basically any type of inflammatory disorder. So let's get started. So what is inflammation? It is a process of your immune system in response to an injury of some sort or some sort of invasion. The physiology of inflammation is unique, and part of your pre-assignment is to look at what exactly happens when inflammation occurs, because it's multifactorial. There's different chemicals of inflammation which are going to cause different physiologic responses. So that's going to be part of what you do when you do your pre-assignment. And I will expect that you bring that into class on whatever day we cover this. It's important to differentiate between acute inflammation and chronic inflammation. Acute inflammation happens when you have an injury, just like chronic inflammation. The difference is with acute inflammation, you have resolution of the problem and healing. Whereas with chronic inflammation, you have continued, maybe persistent injury. And when you have healing, you actually develop some fibrosis and angiogenesis, meaning you develop more blood vessels to the area. You may have an infiltration of the monocytes or the macrophages. And it becomes an ongoing process, and you develop an area that's very fibrotic and maybe not as functional as it used to be. When you look at connecting concepts, inflammation is connected to so many different disorders that you probably could go into just about every chapter in your book and tie inflammation back into it. If you look over to the right on the graphic, you can see cardiovascular disease, diabetic complications, chronic inflammatory diseases like we're going to talk about, some of the osteoporosis, some of the mobility disorders, cancers, metabolic disorders, neurologic disorders. They all have a commonality of chronic inflammation. So once again, this is a big problem, and you can see at the concepts: immunity, infection, oxygenation, comfort, fluid and electrolyte, tissue integrity, and nutrition and digestion, to name a few, but there's more than just that. This week's exemplars are all going to be gastrointestinal in nature, and we're going to cover appendicitis on the acute side of inflammation, and we're going to look at inflammatory bowel disorders from the chronic perspective, specifically ulcerative colitis and Crohn's disease. So the general manifestations of inflammation, whether it's you fell down and hurt yourself or some other inflammatory process, are redness, swelling, impaired function, deformity, and then it becomes site-specific. So heat, redness, swelling, pain, and loss of function, if you look at the graphic to the right on the screen. So I put a slide in here saying the United States is an inflamed nation. And you can see the cover of Time magazine, where suddenly they're finding a link between inflammation and a lot of the problems that the United States is facing, including obesity, asthma, and allergies. Okay, there's a suspicion that asthma and allergies are coming secondary to possibly some of the additives in foods, the gingivitis, the heart disease, immune disorders, Alzheimer's disease. So a lot of the things that are listed in this graphic are things that the United States has in large quantities in its population. And there's the list, once again, inflammation is that common link, that chronic inflammation is contributory, if not causative, for these disorders. The risk factors are going to be dependent on the disorder. Certainly if it's an injury and you fall down, the risk factor is, that you weren't watching where you were going, or you're clumsy, or, you have mobility issues. You could have a family history or ethnicity, especially as it relates to some of the chronic disorders. Some dietary links have been seen to contribute or to fight inflammation. Certainly the more processed food you have, the higher the inflammatory markers may be in your system, whereas some supplements may cause a decrease in inflammation. Occupational and environmental also, once again, can be contributory towards some of that chronic inflammatory process. And the presence of other chronic diseases can contribute towards inflammatory process or inflammatory disorders. Screening and diagnostics, once again, can be considered disease dependent. Depending on the disease, the specific screenings are going to be a little bit more targeted. Whereas if you just want to know if the patient has inflammation, there you got your big four here, WBCs. So WBC spike doesn't just mean they're infected. It also can mean that they have an inflammatory process. And that's an error I see a lot on clinical paperwork where the patient has had an injury, they have a spike in their white blood cell count, and the student wants to think that they have an infection when really what it is their body responding and by the inflammatory process. ESR is a nonspecific inflammatory marker, as is a C-reactive protein, although we did look at C-reactive protein in perfusion. And then chemical mediators. The chemical mediators you think about are things like histamines and prostaglandins and things like that. So sometimes the chemical mediators can be tested to see if you have chronic inflammation. It's possible either your levels will be high or they may be very low because you've used them all up. So don't overthink appendicitis. Probably of all the exemplars we cover in this course, this is by far the easiest and most straightforward. So what does the appendix do exactly? That's a good question. Some people think it has an immune function. Can you live without one? Sure. Okay. Think about what's going on here, and certainly we're going to cover this in class. What are the risk factors you need to consider? And then the manifestations. And that's important because time frames are going to play a part in how appendicitis is going to manifest. And it may not always start as that classic sign that we talk about in class. So here's an example. It begins as dull, steady pain in the periumbilical area, progressing over 4 to 6 hours and localizing to that right lower quadrant. If they say suddenly they have pain relief, no, we didn't fix them unless we went in and took the appendix out. It could mean that they have rupture, and that can lead to peritonitis and sepsis, and it's just generally not a good thing. Appendicitis diagnostics, they kind of are what you think they would be. Okay, treatment is usually surgical and pharmacological. If it's not an emergent situation, they may consider antibiotics to try and decrease some of the inflammation that's going on. If it is emergent, they'll take the patient right to the operating room and they can perform an open or a laparoscopic appendectomy. Inflammatory bowel disorders is an umbrella term characterizing Crohn's disease and ulcerative colitis. They're both characterized as inflammatory bowel diseases. Do not confuse this with irritable bowel syndrome. Okay? That is not an inflammatory bowel disease. It's not in the same classification. So these two particular disorders are the ones we're going to talk about. They have different pathophysiology and different manifestations and complications, but their treatment and some of the pharmacology is going to be similar or the same. So you'll find in class that we're going to separate them out to discuss pathophysiology and complications and manifestations, and then we're going to bring them back together when we start talking about treatments. This is a lovely picture. If you look to the right, it is a EGD showing the cobblestone appearance of inflammation that occurs with Crohn's disease. To the left, you have someone who is sitting on the potty, and it's surrounded by some of the important things you need to think about as it relates to Crohn's disease. Here is a graphic that also discusses differences in terms of how Crohn's and ulcerative colitis happen, where the inflammation occurs, and you can see with Crohn's disease it's actually a transmural inflammation, so it goes into the submucosa and you develop what they call skip lesions. In other words, there's an area of inflammation and then an area of normalcy. Over time this leads to strictures, and sometimes it can lead to ulcerations and fistulas. Ulcerative colitis, on the other hand, is usually inflammation in the mucosal layer which continues to shed, and so you end up with a problem with bloody diarrhea, and usually it's a continuous pattern, so you're not going to have the patches that you have with Crohn's disease. You'll also note on this slide they have the small intestine for Crohn's and the large intestine for ulcerative colitis. That is significant. When you're looking at care for the client who's got inflammatory bowel disorder, it's a three-prong approach. So you have surgery. If it's a continuous process, now it's not going to be your first thing, but you can have a colectomy and take out the area that's causing the problem. There's a three-prong approach with pharmacology as well, and then also dietary. With the pharmacology, they usually will start with things that are going to decrease inflammation. Aminosalicylates, which is an aspirin-type NSAID substance, or antibiotics, and then they may progress to corticosteroids for the anti-inflammatory and the immunosuppressant effect, as well as immunomodulators. So those are the ones that end in IMAB, I-M-A-B, like infliximab, that are going to alter the immune response. And you can see infliximab actually also comes up into the severe, depending on how it is, and that's when you look at surgery. Okay, this concludes the lesson or the intro for the concept of inflammation. For your pre-class assignment, please consult Blackboard, and there's a worksheet on immune physiology, as well as some specifics on ulcerative colitis and Crohn's, and on different types of ostomy procedures. Thank you very much for your time and attention, and I'll see you in class.